Hello, everyone. Welcome to another Wednesday VMR. First of all, my apologies for my absence over the past month. I was out and about in the world traveling, but it's good to be back. And there's nothing better than a Wednesday VMR. I have some good news and I have some sad news. Sad news is like, unfortunately, Prof. Rez can't join us today. He's busy supporting his interns on service. Good news is that I get the absolute pleasure of discussing with the one and only Andrew Sanchez. Andrew, thank you so much for jumping in.
Yeah, of course. Very, very happy to be here, Sharmin. No way I could say no to that text message. So looking forward to discussing with you. Good to see everybody.
I love to bug you all. So thank you so much, Andrew. And a big shout out to Shreya and Gerardo for scribing and doing teaching points, as I remember that I have not made them co-hosts yet, and I'm doing it now. And Michael, thank you so much for joining us. Do you want to unmute yourself and introduce yourself to the crew?
Yeah, thanks for having me. I'm Michael Ward. I'm a first year internal medicine resident at UIMS in Little Rock, Arkansas. Happy to be here.
Yeah, thank you so much for being here. We're super excited to learn from you. And yes, a big shout out to Arvin, our youngest CP Solvers member, who's here as well and learning through osmosis. uh, and if you can get the board up, then we can get started. Amazing. All right, Michael, we're ready for you.
Okay, so the chief complaint today is going to be 1 day of nausea, vomiting, and new fever. Um, For his HPI, like I said, again, started 1 day prior, 6 to 7 episodes of non-bilious, non-bloody vomiting. He has a chronic cough, clear phlegm. He reported some difficulty urinating to us, no real blood in his urine. He denied any night sweats, weight loss, abdominal pain, chest pain, or new rash. Living in Arkansas, no recent tick bites that were reported, no sick contacts. Um, he has a past medical history of hypertension um, that is treated and stable, hyperlipidemia, he's on a statin for, type 2 diabetes, um, history of prostate cancer, status post radiation, seronegative rheumatoid arthritis, dry eye syndrome, and then chronic DVTs, which he's on apixaban for. Only surgeries he reported were a ventral hernia. Um, he was a former smoker, occasional alcohol use, not really significant for our purpose today. Um, and he was a former veteran and used to work in on a naval ship in the Mediterranean during his service. Um, I might not mention this is a 78-year-old gentleman. For his medications he takes, he's on apixaban, tamsulosin, lisinopril, metformin, loratadine, glipizide, gabapentin, finasteride, amlodipine, methotrexate weekly, sulfalazine, prednisone, hydroxychloroquine, and erythromycin.
Is this a
Um, Sorry, go
is this
ahead.
a good place to stop, or do you want to share some more information?
Um, I can give you some of the labs that were shown in the emergency department.
Okay, sure.
Vitally, um, he had a Tmax of 100.7. His blood pressure was elevated at 162/86. His heart rate got up to 116, and he was satting on 95% with 2 liters nasal cannula. His white blood cell count, or his CBC at that time, everything was pretty stable except his white count was 14.5, hemoglobin of 11. ESR was normal at 16. ProCal was a little low at 0.07. His BMP was unremarkable. He had an iron studies that were consistent with iron deficiency anemia. His LFTs were within normal limits. His lactate was elevated at 4.6. We here at the VA at UAMS, we do a fluid panel. I think it's just a drawn respiratory panel. It was negative. Blood cultures were drawn. A UA was obtained. EKG showed a little bit of sinus tachycardia, nothing concerning. Chest X-ray showed no infiltrates, no consolidation, no effusion. And then he had an echo done, which showed a LVEF of 55%, some diastolic dysfunction, but no vegetations. And empirically, they went ahead and started him on vancomycin, Zosyn, and given 3 liters of fluids.
Awesome.
Right. Sorry. Can I just ask one clarifying question?
Yeah.
Was it seronegative RA? Was that the diagnosis?
Yes, ma'am. He has a history of seronegative rheumatoid arthritis.
Wonderful. All right, Andrew. Mike to you.
All right, we got a lot to chomp on here, Charmian. This patient's presenting with very non-specific symptoms, but very acute symptoms. In terms of the analysis of nausea, which is coming in with, usually we like to try and attach that to something, but it sounds like his only other accompanying symptom is fever. And just to clarify, Michael, was the cough chronic too? I wasn't sure. I think I heard it was chronic, or was that acute?
Chronic cough.
Chronic, also I thought I heard. Okay, so it sounds like that's chronic and also with clear phlegm, which is not kind of that purulent sputum you think of in terms of someone who's coughing up the pus that accompanies pneumonia. So really what we're left with is just this very non-specific signature for inflammation here that's acute, and clearly they're being treated as if they have sepsis, since we just heard that they are given MRSA coverage, gram-positive coverage, and Zosyn, very, very broad gram-negative coverage with Pseudomonas, kind of while the dust settles and we figure out what's going on. So I think we should certainly take the approach that you all took for this patient and try and figure out if this patient has sepsis, what is driving it. So, the most common reasons that people have infection include skin and soft tissue infection. It doesn't sound like he's been grabbing at any extremities or anything like that, leading to some sort of cellulitis. Of course, he's coming in with GI symptoms, which could be reactive to just something systemic. Like I've seen this from pneumonia, nausea, and vomiting. I've seen this from pyelonephritis, super nonspecific. But we can consider, we don't have any abdominal imaging for this patient. What's going on in the belly? I think he's certainly we're able to buy at this time a CT scan with IV contrast to look for inflammatory bowel pathology, hepatobiliary disease, despite the negative LFTs, all of this. And then even with the chest X-ray is pretty poor sensitivity for pneumonia. I'd say someone coming in dyspeptic, usually a chest X-ray will catch a pretty impressive focal infiltrate for them to be this sort of sick looking. There are these pneumonia syndromes like PJP, where classically the chest X-ray is really, really poor at detecting those things. But those sorts of patients don't usually come in like this kind of acutely ill. Like this is just such an acute syndrome. But I would say this is like inflammation of fever and inflammation of unclear source. And really the first pass of that in terms of, oh, you're going through FEO, it's all about making sure you don't miss infection, which is kind of why the first step in FEO diagnosis is really cross-sectional imaging of the entire body. That way you can catch things like hepatic abscess, inflammatory bowel pathology that you wouldn't see on an X-ray, including a chest X-ray. So yeah, Charmaine, I feel like it's all about management reasoning at this time. I kind of want to see CT torso, what's going on in the lungs, what's going on in the belly with IV contrast, just to see if we can kind of find something that's driving this physiology right now.
Yeah, I totally agree with you. As like someone who has like history of autoimmune disease on some immunosuppressive therapy, who's like coming in kind of with acute onset of like inflammatory syndrome, with like kind of like this nausea and vomiting. And as you mentioned, the nausea and vomiting is like so non-specific, but oftentimes like I think for us it's like intra-abdominal pathology that is like number one. Number two, the one thing that I was like I think about like it would be nice to like to have kind of an exam to see if that's corroborated by any like abdominal tenderness or anything like that. Um, So I think like cross-sectional imaging would it be key. I think in terms of the lactate, thankfully, sounds like we don't have like a blood pressure, but it would be like helpful. Like it was like tachy, febrile. It would know like are we dealing with like more like kind of sepsis. It sounds like it's severe sepsis, whether in the shock physiology or not. But someone that probably would benefit from some IV fluids, and as they given, oh, 3 of the IV fluids. There we go with Zosyn. The one thing that is like caught my eyes, to be honest with you, was that like 2 liters oxygen requirement is like so kind of thinking about like is it truly like a hypoxemic respiratory failure in a setting of a chest X-ray that is negative. I think all roads, as you mentioned, reads to the a tube of truth. And we know we're not dealing at least like with like kind of like flu, RSV, and COVID for this patient. The one thing that, in someone like 78-year-old autoimmune disease, the one thing, I just like don't want to make sure I miss any like cardiac pathology. So maybe getting an ECG, a high sensitive trope. Sounds like echo doesn't show any wall motion abnormalities, especially like veterans. They always like present the way they want to present. Um, and like making sure we don't lose sight of that. In terms of uh, and like making further, the other thing that I was like wondering with the elevated lactate, someone who takes a metformin, whether there's some component of type B lactic acidosis. But your first path is always like that lactate represents hyperperfusion until you proven otherwise. And in terms of like her past medical, his like past medical history, it's just like found the seronegative RA always is an interesting diagnosis, and kind of whether that will become more relevant or not. As you mentioned, Andrew, I totally agree that like number one, number two, number three at this point is like make sure you're not missing any infection and stabilizing the patient. And one of like one of those no misdiagnosis in someone like who's presenting with like kind of nausea is just make sure they don't have any bowel obstruction, any wall bliss, anything that requires a more like surgical management. Anything else, Andrew, from your perspective?
No, it sounds good. I think we're gonna get blood cultures throughout the people mentioned in the chat, UA blood cultures in addition to our imaging. And yeah, let's see what all that all shows us. Back to you, Michael.
Oh, okay. So what we ended up doing was he was admitted to the general medicine team, and like you guys said, we got a CT abdomen pelvis, um, which really didn't show anything other than they put a Foley in the ED. I guess he wasn't having good urine output, if I remember correctly. He just had some like chronic urinary bladder wall thickening. Um, Nothing really significant. However, for the next few days, blood cultures weren't growing anything. He was still fevering. For the next 5 days, he had T maxes above 102. I think the highest was like 103.2, and kept getting CBCs. White blood cell count was high with a huge neutrophilic predominance. Um, other values to consider at that time. His sodium began to decrease from baseline, which was 135 to 140. It was now for the next 5 days 129 over 130. Um, he also began to become more altered, slow responses, resting, and he had a resting tremor and was complaining of a headache, and still on 3 liters of nasal cannula, despite not needing oxygen requirements at home. We were concerned that he might have some type of uh, pulmonary embolism going on. We obtained a CT PE. It was negative for PE. He had some bilateral pleural effusions, which were treated adequately for. So really, what we were trying to figure out was, what's going on with his fever? Why has he been fevering despite us giving Tylenol, breaking the fever? We were stuck at that point.
Very interesting. Sharmin, do you want to take this one first?
Sure, we can go back and forth. Yeah, very very interesting case. So it sounds like what we know is that at least like with like a negative CT abdomen pelvis, there's nothing that would kind of from like a hepatobiliary sorry, from hepatobiliary, GI symptoms, renal symptoms, like from those perspective and organs, we're not. It doesn't seems like we're dealing with an infection that is like intra-abdominal. I'm still very curious with, and I'm glad you guys got a CT chest to see what we're if there's any pathology there. And I think like someone who has like a bilateral effusion, oftentimes like a unilateral effusions would be, we often think more about like whether that could be like an empyema or an infection. But I think like in someone that I don't know exactly what I'm dealing with, I would tap that effusion if it's big enough to be tapped to get some additional information. Oftentimes like effusions can be hard for antibiotics to get into and can become a nidus of infection. So I want to make sure that sorry guys, that is not no, that is not a source of the patient's symptoms. The other thing that I was like thinking about with like, okay, maybe Andrew, do you want to take over so I can drink some water?
Yeah, Sharmin, please be well over there. Um, yeah, I think the tension I'm facing is the encephalopathy here kind of secondary to some systemic process and not something to worry about, or are we started to get kind of worried that this is where the problem is sort of living? Because it sounds like we're kind of surveying the abdomen, we've surveyed the chest, and we're not really seeing anything like very convincing here for a nidus of infection. So if you're telling me that kind of CNS deterioration is kind of next, especially with tremor too, it makes me wonder, okay, what's going on there? I think first things first, treatment failure, because they're getting treatment, right? They're on vancomycin and Zosyn. Is there a reason that that treatment is inappropriate empirically for perhaps is bacterial meningitis that this patient actually came in with? Which in retrospect, thinking about how much nausea and vomiting they were having, with meningeal irritation, high ICP, certainly that can drive a lot of nausea and vomiting. Zosyn actually, so Piptazo, I don't believe has good CNS coverage. So actually at this time, if we're kind of worried that this is a meningitis sort of syndrome, then we should actually change that to ceftriaxone and I think start covering for viral encephalitis too, and just go ahead and start acyclovir. The only addition to empiric bacterial meningitis coverage is the listeria coverage, which I forget, Charmaine, you can remind me or someone in the chat. I forget if age greater than 50 alone is a risk factor for that and is a reason to do it. But just to say it out loud, that's something else to consider. So I would say, just given the acuity of this over one day, meningoencephalitis is a very broad differential diagnosis, but I think you prioritize kind of typical bacterial causes of that and viral causes just based off how acute this was. So, HSV encephalitis, pneumococcal, Neisseria meningitidis, some of these things, you would think, okay, well, the blood culture that he's been cultured several times, like it should have maybe grown something for some of these syndromes. Like I think like Neisseria probably pretty acute. Maybe would capture that, but maybe not. Maybe that's a knowledge gap for me. So I think probably what we're gonna need next is at least a head CT to start just to assess for signs of high ICP, and probably we're heading towards an LP at this point would be my guess. And yeah, I don't know. This is kind of a scary case now, Charmy. Are you better now? How are you?
Yeah, I'm much better. We can defer like a speech and solo eval for a few more minutes. And yeah, I totally agree with you. I definitely the other thing that I was like thinking about whether there's like a reason to have an increased ICP, and that was the reason why maybe that this patient was like having more like nausea and vomiting to begin with. So starting with like a non-con head CT, make sure we don't have any space occupying lesions there. And also, I brought in the antibiotics to cover intracranial processes and meningoencephalitis. I totally agree with. Yeah, I'm like super worried about this patient. I would also like make sure to get a gas as well. And whenever there's an altered mental status, I'm basic. I go back to our missed mnemonic, and whenever a patient develops a new symptoms, I try to like pause and then like reframe a patient just to make sure I'm not stuck into an old framing, and like making sure to repeat make sure there's no metabolic, make sure the liver is still doing okay, making sure the kidneys still doing okay. And then as you mentioned beautifully, Andrew, in terms of like brought in both the antibiotics and the infectious workup. This is someone who is on steroids. I don't actually know the dosage of that. And the other thing to be aware of, and I'm not sure if like steroids are being held or continued, is that if this patient has been like chronically on steroids for a while, and if we are pausing them, just being mindful that we can induce some adrenal insufficiency, and being mindful of the patient's vital signs as well. So like management wise, like this patient is quite fascinating as well, and also being open to the multiple things going on. But I think when in doubt, you just like need more information. So the LP, Thora, trying to get some more data to be able to help better um, for us to be able to better understand what problem we're trying to solve. Because if I'm still stuck in like a broad like systemic inflammatory syndrome, that perhaps that is now leading to like perhaps some toxic metabolic encephalopathy, but that is still very broad. I'm having a harder time like narrowing it. What about you, Andrew? Anything else?
No, no, I was just like looking at all the old stuff. Like, are there any other clues here? And I'm like, okay, so the chronic cough is chronic, but why? Because we didn't get a COPD history. He's a former smoker, so he could be undiagnosed COPD. But I'm wondering if the chronic cough is part of the acute syndrome. I think the only other thing to pull in here, based off of where the patient is located, is cocci, because cocci can definitely present with chronic cough that kind of brews for a bit, and kind of a chronic meningitis syndrome right here is obviously presenting pretty acutely. That's one of kind of like the murder weapons of cocci is actually meningitis. So maybe, I don't know how you all practice out there. I don't see cocci over here in Boston. Maybe even at this point, it's worth starting empiric coverage for that, just thinking about whether or not that may be involved to the chronic cough. But let's see what the head imaging shows and what the LP shows.
Perfect. So what we first did is Legionella is pretty big in Arkansas. We empirically just started him on Doxy, even though we didn't have the results back. That sodium low, it's always safe to just go ahead and put him on Doxy. At that time, we got a Legionella panel. It was negative. Someone in the comments mentioned LFTs. I think they're referring to maybe ehrlichiosis. We do get a lot of ticks here that are um, uh, indicated for Ehrlichia, so we got a panel on that. It was negative. During this time, his oxygen requirement got really bad, so he actually went to the MICU for like 3 days, trying to get his oxygen all back up and fine. Like you guys said, we got the CT head with contrast, no acute intracranial abnormalities. This prompted us to be like, well, he's still really encephalopathic, really altered, not answering my questions appropriately. Let's go ahead and get an MRI brain. That was also negative. So we were like, okay, what else do we need? What else can we we were just stuck. This is a guy that, we feel like we would have had treated by now. His blood cultures were negative. Like to date, we redrew blood cultures. They were still negative. We redrew fluid, got a procal again. It was normalized at 0.14. So then we were like, okay, let's just order all the weird labs. So um, we got a crypto panel negative, blasto negative, histo plasma negative, Bartonella because during the Mickey stay, his wife might have mentioned he has a lot of cats. We got that panel; it was also negative. Like I said, we repeated the blood cultures; they were negative. Um, EBV was within normal limits. We also sent out a CMV and did some hepatitis, Hep A, Hep B, Hep C, all non reactive. And we were kind of stuck. So then we ended up getting the LP. And if I can report the results here, he had an opening pressure of 20 centimeters water. His protein was elevated at 105. His glucose was at 131. White blood cell count was 18. RBC was 2. neutrophils were 2, and his lymphocytes were at 66. So I don't know if y'all want to discuss the results about that, and kind of interpret what that meant, what those.
Yeah. Yeah, definitely. It's a great stopping point here. So I would say something we're gonna have to solve now is the acute hypoxemia. And sorry if I totally spaced out there, Michael. Was there like repeat chest imaging showing like, multifocal kind of alveolar opacity, something that like would be explained? I forget if you mentioned that.
That's nothing. We repeated imaging. We got the CTPE again while we were in the ICU, just in case like he had work like a new PE, and it was the same as previous, just some small bilateral pleural effusions. I know you guys mentioned maybe getting a thoracostomy, and looking at that fluid. The radiologist didn't deem it big enough for a good fluid collection, and we weren't comfortable at draining it at that time.
Got it. Okay. Maybe Sharmy, I'm gonna need your help there then, because I'm not sure how marked the oxygen requirement increase was, but I just want to make sure that if that's part of the problem we're trying to solve, we kind of account for it. But no, I think we see lymphocytic pleocytosis here. In the absence of this having gone on for a while now, which I don't know, it sounds like maybe he's been in the hospital for a couple of days now. I still feel like it's a little early for kind of the cell differential count on the LP to shift from the neutrophilic kind of predominance you would see for an acute bacterial infection to lymphocytic. So I wonder if the lymphocytes are actually telling us that no, this isn't bacteria, but this is going to be something atypical bacterial, like TB, or is it something fungal like cocci? We still don't have our cocci test, so I'm still keeping that in mind. Or something viral too. I was asking about the alveolar infiltrates because I think around there you all have something called hantavirus, which can cause pretty acute, profound capillary leak and a lot of pleural effusions acutely, a lot of alveolar edema acutely, and no doubt I bet kind of an altered mental status encephalitis picture too. So that's something we can kind of keep. But I do think that the lymphocytic pleocytosis will be helpful to us. And regarding like the negative brain MRI, it's not uncommon that you have this meningitis picture or encephalitis picture where the MRI is completely negative, but then you get the LP and you see that there's inflammation there. So yeah, definitely not stopping at the MRI there was really important for his case because the LP here I think tells us the story of what's going on. So yeah, maybe Charmy and I'll ask you. I'm gonna keep thinking too because I'm still kind of gathering my thoughts on kind of where we go from here.
Yeah, quite tricky. With the hypoxemic respiratory failure, specifically with like kind of a negative imaging, is like an interesting differential to think about. And the part that I'm stuck in, one thing is like when people are hypoxemic, you want to make sure that it's not a ventilation issue, right? So making sure like it's not a PCO2 that is driving it instead of altered mental status or any central causes, which I assume probably ABGs and BBGs were done, and that was like not the case. If the pathology is not in the lungs itself, then I think about like whether there is like any AVMs or any like cardiac shunting or like shunting that is happening somewhere else in the body that is like causing this hypoxemia. But I'd be curious to know how the patient did, like if the patient was altered, had an aspiration event, had a hypoxemia, had a worsening hypoxemia, and then it completely resolved. Like we're in a different bucket rather than like if it was like continuously patient remained hypoxemic. But yeah, if they are still hypoxemic and repeat CT imaging didn't show any pathology other than small effusions, then I think more about like whether there's like a cardiac etiology in a setting of like a ASD, BSD, or something that is causing some shunting. Or at times like you also see like pulmonary AVMs, and I think Mark already told us that at this like the CTPE that was done, it was negative for any pulmonary embolism, which is another thing that I think about. So if it's not like an alveoli or parenchymal problem or a bronchial issue, then I think we are left to investigate the vessels a bit more. And in terms of the lymphocytic pleocytosis, I totally agree. Unfortunately, the lymphocytic pleocytosis differential is quite big. Um, but oftentimes, like I think, as you mentioned, like the pyogenic shifting that happens. The other ones to think about, like the zoonotic, the granulomatous infections that you mentioned. And I think, like, with someone who's like immunocompromised, thinking more as you did about fungal. I love that you were also, Andrew, was asking about like whether it's like a bilateral pagiopathy, because I'm like, this has to be PJP, right? And someone who's like with steroids, I'm just like, oh, maybe it's just PJP. Um, but the other things to also like think about, like the arboviruses, like the viral etiology. So, and I think like most of that were sent already. If not, your HSV, your HIV, and then I think like molds are another one to start thinking about in this situation. So like viral, kind of bacterial, thinking about like your zoonotic infections, fungi. The crypto was a negative, but like endemic mycosis is another good thought. And whether like empiric, like fluke or something. You mentioned a cocci too, would be a good call. And I feel like we're still in the world of like making sure this is not an infection in the setting of like, and then like we're kind of the other ones to kind of throw out lymphomas can do and anything they want to do, as well as like autoimmune etiologies. Again, like I'm not sure if I want at this time. In reality, I don't know if I would spend much time in the world of like autoimmune just yet. I think like we're, because this patient is immunocompromised, we still has to make sure like um, we make sure it's not like like a fungal infection. Um, and I think like then you think about like in terms of the autoimmune diseases, less likely in a setting of non-neuro deficits for this to be any of the like demyelinating issues. The patient does have like this questionable like um, seronegative RA. So at some point, I think we gotta have to decide if we want to invest more cognitive energy, whether this presentation is encephalitis related to a type of like underlying autoimmune disease or not. Um, the other one, if like if this is not an infection, like NMDA is a big one that I often think about in these patients. So yeah, I think like the pleocytosis, the lymphocytic this like a sorry. It just kind of like broadens the differential even more. I still am looking for that pivot point to be able to narrow the differential, which I don't think we're there, or I can't identify that yet. Um, so I think if I'm like trying to say like, okay, how am I gonna Google or Chat GPT this patient? I'm just like the hypoxemic respiratory failure without any like parenchymal signals is like one part of this presentation, and then kind of the lymphocytic pleocytosis in someone who has underlying autoimmune disease. What are you thinking, Andrew?
I love it. I think we should keep going. I'm eager for more now.
You guys were so close. So I'll address the respiratory requirements first, and then I'll kind of talk about our thought process into what was going on with the altered mental status and the fever. For his oxygen requirement, one day in the ICU, we were able to wean him down to like 2 liters, and his infection started cleaning up. It turned out that those really small pleural effusions were actually kind of causing some of his breathing issues, um, and it just sort of, I don't really know exactly what happens, but it's sort of just the antibiotics we kind of had him on. Once he completed those courses and we're on for a little bit, it kind of really cleared his breathing. And just one day he was just like, I feel better. Um, got admitted back to the floor and still fevering. So I just threw out, an idea of like, what if this is West Nile? Um, we got a panel in Arkansas at our hospital. You have to do a send out lab, IgG and IgM, and it goes to a private company. It's called LabCourt. and they run it in through a centrifuge and mix it, and you get the results about a week later. So while he was on the floor, fever improved, mental status changed, um, and he was alert and oriented times three, off oxygen, doing well. And we were just keeping him for rheumatology to come evaluate him for his seronegative RA because he hadn't been evaluated in a while. And during that time, I got a result back that he was actually positive for West Nile virus. And so, to be honest, I was kind of shocked that that was the diagnosis. It's very rare here in the state of Arkansas to be diagnosed with West Nile virus, and it's such a like you guys are talking about. We were thrown for a loop for this entire admission through discharge because very non-specific symptoms the entire time. Just fever. For a little bit of the stay, he had altered mental status, but then he went back to his baseline. Um, all the tests we threw out were negative. So there was a lot of good teaching points from this case. I can go over um, just to kind of give a brief education on West Nile. Symptoms are only seen in 20 to 30 patients, and they roughly last about 3 to 10 days. Now, there's two really main common manifestations of West Nile. You, of course, have the West Nile fever, which is the fever, headache, back pain, myalgias. You sometimes get a rash on your chest, back, arms. Um, and then the one we were concerned about now is the neuroinvasive disease. You'll have the fever with encephalitis or meningitis. And you can have asymmetric flaccid paralysis, which he never really demonstrated. He did demonstrate, though, some confusion, tremors, myoclonus, rigidity, postural instability. It was a good thing for me to learn because if you see a patient who's demonstrating, even like Parkinsonian like features, something on your diagnosis or on your differential should be West Nile. Reading from Up to Date. Um, and in the world that I practice in internal medicine, you'll see more symptoms for encephalitis rather than meningitis in these patients. Um, some other rare symptoms you can have ocular issues, rhabdomyolysis, so always good to get a UA, hepatitis, pancreatitis. Um, so for diagnosis on him, I think it's really hard to diagnose West Nile. It's I think for me and how I build up a differential, it's kind of in the back of my brain, not really at the forefront because it's such a rare infection. Um, but for diagnosis, when to test, if you have an unexplained fever, you have encephalopathic symptoms, or meningitis or flaccid paralysis. And you really want to think about this virus during warm seasons and if you're in a warm climate. And I think most of the time you'll see it in, places that are close to the equator. Um, and actually, Arkansas, we're actually getting more cases per the CDC. At the time we diagnosed this patient, there had only been 4 cases reported in the state of Arkansas. Um, Fast forward 2 months from now, I think those numbers are up to like 10. So a pretty good increase in 2 months. Um, Diagnosis, you want to get a serum and CSF, IgG, and IgM, and you'll run it through an ELISA test. That is diagnostic. The LP is not diagnostic. It can just tell you that you will have, high protein, lymphocytic predominance, some mononucleocytosis. Imaging, kind of like this patient, CT is not reliable. MRI, you can see some increased signal abnormalities, but it's not going to tell you a specific cause. Um, One thing we didn't do with this patient that we probably should have done looking back is getting an EEG for this neuro evaluation. It can show you generalized slowing in your frontal and temporal regions. And so for the treatment of West Nile virus, like any other virus, mainstay is supportive. Um, Corticosteroids, there have been some trials that has been used to help patients with neuroinvasive West Nile disease. The sample size is really small. I think it was like a trial of 30 to 35 patients. And you can give IVIG as well. Obviously, prevention, wear your bug spray, get rid of that standing water around. And the last thing I have is before questions is I was looking to see, like, with recent climate change problems, is the frequency of West Nile going to increase, especially in the southern parts of um, North America and the United States. And what I found was in UCLA in about 2015, they did a global uh, climate change trial where they tracked increased probabilities of West Nile rates by the years of 2050 and 2080. I don't know if 2080 is going to apply to all of us in our practice, but for some of us, 2050 might. Um, it's supposed to increase by over 85% of cases, especially in the state of Arkansas. Um, so I believe by when I'm well into my practice, I'm going to see a lot more West Nile cases than I would think I would see now.
Wow. Michael, that was awesome teaching. And I love how you like projected forward too. Basically told us like this is an important case because in 25 years, you're probably going to see this presentation more and more and more. I really liked it because it really broadened my illness script for West Nile, which I kind of know for causing myelitis and kind of like flaccid paralysis. And in the back of my brain, I heard of like basal ganglia stuff, and I think Charmian, looking back at that tremor, probably there was some signal for that there. But my only other reflection is in terms of, when do you stop trying to find those culture negative kind of bacterial fungal organisms and start moving on to viruses? Like where you draw the line for that, kind of when you send that testing, I'll be thinking about that for a while because I was definitely still worried about something with that immunosuppression, which still could have made his viral infection worse, I think. But yeah, what do you think, Sherby?
Yeah, Michael, thank you so much for presenting this case. It was such a really such a wonderful case to kind of think about and reflect on. And as you mentioned, yeah, I think like I heard Arkansas and West Nile did not cross my mind. So I think your point about like the changes and like climate change and how that will change how we need to think about like especially like mosquito-borne illnesses is a really really great one and something that I would definitely be more in my forefront as well. And yeah, and I agree. I think like with West Nile, I've seen like some of the more like kind of classic presentations, and this one threw me for a loop with the hypoxemia. And this is why we love clinical reasoning because it will like allow us more like spaces to kind of reflect and get better at what we do. And I think yeah, when it comes to like the wire, the other part that I was like thinking about, Andrew, is that you know. It's at times like with medicine is like using your treatment, we often think about like, oh, our treatment as a diagnostic tool, but also like thinking about the natural progression of diseases and natural history of them, like a viral infection like a West Nile on its own, it's going to improve while you have them on antibiotics. And if you have never sent that test, we would have maybe attributed to another pathology. So kudos to you, Michael, for thinking about the West Nile. And I think it's a good one to add to your like like HSV encephalitis similarly can cause like them similar, and if HSV is negative, thinking about West Nile too. In addition to HIV, I think it's the one to remember from a lymphocytic pleocytosis perspective. Yeah, I have like so much to reflect on. This is an incredible teaching. It was really, really fun to think through this, although I felt like I was like, what is happening? It was how I felt internally. Andrew, any other thoughts?
No, happy to be here with you, Charmaine. Good to see you all.
Thanks again, Michael, for being here. Come back soon. We would love to have
Oh,
you back and learn from you more.
yeah, if I find something that is going to throw everyone off for a loop, I'll be sure to come back.
Or not,
Or
whatever
not.
you
Yeah,
want.
yeah. Yeah, or
Whatever you
not. Or
want.
I could do a very simple one too.
Thank you so much, Michael. Big shout out to Shreya for keeping up with all of the case, and Gerardo to you for teaching.
Oh yeah, thank you so much, Sharmin. Well, for the teaching points, we initially were presented with a gentleman of 78 years old that presented with nausea and vomiting and new fever. And we know that in this presentation we can't miss inflammation, so we gotta do whole body imaging to look for a focus of a possible inflammation. Also, this patient was seen with an elevation of lactate, so this could indicate a possible sepsis. And because this gentleman was presenting with fever, nausea, and vomiting, that could indicate also a possible meningitis. That an empiric treatment was suggested with ceftriaxone, but vancomycin, and especially ampicillin, because this is a gentleman older than 50 years old, who are more prone to inflammations or infection with Listeria monocytogenes, as well as neonates, but this is not the case. And also we can cover for with acyclovir for viral causes like the HSV2. And also, um, it was mentioned that doxycycline should be used to cover for Legionella in endemic regions, especially because it is known to cause low sodium, like it was found in this patient. Also, there was a really big part of our reasoning was the analysis of DLP because it presented with high protein and lymphocytic pleocytosis, which could mean autoimmune, cancer, and infectious. Um, and well, these are very big pockets, but it turned out to be an infectious cause, which was the West Nile virus, and there were a lot of pearls mentioned at the end of the case, but I just wanted to mention one of the more importance that I think were mentioned, which are the invasive presentation of West Nile virus, which was this present case with encephalitis, meningitis, and asymmetric flaccid paralysis. And it was mentioned also in the chat by Valeria that it has a special tropism for basal ganglia. Also, one thing interesting is that it can present with neutrophilic pleocytosis, which is normally linked to bacteria, but in this case, it can also be presented in a West Nile virus infection. Could cause Parkinsonian features, ocular issues, rhabdomyolysis, hepatitis, and pancreatitis. And it is more likely in warm seasons with a higher likelihood close to the equator. The increased incidence could mean that could be linked to climate change. And the diagnosis is made with MAC-LISA on serum to look for IgM on the 8th day after symptom onset, and CSF is non-diagnostic. So these are the teaching points. And thank you so much for for today's case.
Such wonderful teaching points. Thank you so, so much. Thanks all again for joining us. Big shout out to Michael for presenting. Andrew, thank you so much for stepping in. And all of you all. Can't wait until the next time. Gotta go learn more about West Nile. Thanks all. Bye.